Hello there, it's Luke, and in our third and final tutorial, looking at tissue fluid formation, we're going to consider how the Starling forces might be implicated in the formation of pulmonary edema, that life-threatening sort of hypoxic clinical situation that we may find our patients with. Now, to do a very quick recap, we have already said that there are essentially two forces at play moving the fluid between the intravascular space within the capillary and the interstitial space in the tissues surrounding the capillary. And those two forces are hydrostatic pressure, which is mainly due to arterial blood pressure, which forces the blood through that permeable, semi-permeable rather, wall of the capillaries from the intravascular space into the interstitium. And then we've got proteins and big molecules exerting what we call oncotic pressure, which draw the water and the fluid back into the intravascular space. And any excess fluid that leaves the intravascular space, leaves the capillary, and is within the tissues, is in health drawn back in to the circulation via the lymphatic capillaries. Now we have a really similar setup in the lungs, and so within the pulmonary capillaries we still have hydrostatic pressure, which is generated by the pumping action of the right ventricle, so the venous return and then the pumping of the right ventricle. And we still have all those same proteins and cells within the pulmonary capillaries which are exerting that oncotic pressure and drawing fluid back into the intravascular space. And there's really sort of very little sort of net filtration, so very little excess fluid pushed out of the intravascular space and into the tissues of the lung. Now, if we consider the pulmonary circulation compared to the systemic circulation, by which I mean if we think about the right ventricle, which is a lot smaller and generates a lot less pressure than the left ventricle, the pressures across the capillary bed, so across the blood vessels, if you like, within the lungs, are a lot smaller. So the right ventricle can generate, 25, 30 millimeters of mercury. You can pick the numbers up. And that's enough to sort of force blood through the pulmonary valve, through the pulmonary arteries and arterioles and into the pulmonary capillaries. And then again, there's quite low pressures as the blood comes back in through the pulmonary veins and drains into the left atrium before the left ventricle generates obviously that huge force that it does to pump the blood around the body. So essentially all I'm trying to say is the pressures within the vessels, within the lungs, are much smaller than the pressures, right, so the hydrostatic pressure within the systemic capillaries or systemic circulation. And we can see that we've drawn the blue hydrostatic pressure arrows a lot smaller for our diagram looking at the pulmonary circulation. Now, the situation we've just described is discussing a healthy heart, and here's an echocardiogram, what we call an apical four-chamber view of the heart. And you can see here we've got these four chambers, and the most significant one here is the left ventricle. It's the biggest, it's the most muscular, it's what's pumping the blood around the body, and it's pumping the blood away from the lungs around the body, and that's significant. And like I say, this is a healthy heart. Now, if we consider a failing heart where the left ventricle isn't pumping as well, and you can see it's here, it's all dilated, it's big, it's round, you're barely sort of squeezing any blood out at all. Because that blood isn't being ejected out, the blood is pooling within the left ventricle, and so this will have a knock-on effect further back. So if we consider again our heart, and so we have the left ventricle that is perhaps beating much less well, and so we have blood pooling within the left ventricle, and so there's an elevation of that sort of diastolic pressure, if you like, within the left ventricle, and then that has a knock-on effect, and there's more pressure within the left atrium, which will have a knock-on effect, meaning that there's more pressure within the pulmonary veins and therefore the pulmonary capillaries. Okay, so you've got sort of backing up of pressure because the left ventricle isn't beating very well. And so, as we said before, the pressure within the pulmonary capillaries is much less than in the systemic capillaries and systemic vessels. But in the instance where you've got a failing left ventricle, that hydrostatic pressure, because it's sort of backing up at the sort of venous side, is elevated throughout. And so you have a greater hydrostatic pressure pushing fluid out of those pulmonary capillaries. And the oncotic pressure hasn't changed. There's just that sort of that same amount of proteins and cells within the pulmonary capillaries drawing the fluid back in. And so you have a greater net filtration because the hydrostatic pressure is greater than the oncotic pressure. And that's how come we end up in left ventricular failure, ending up with pulmonary edema. And if we have pulmonary edema, we generally have sort of dyspnea, harder work of breathing, and the ultimate knock-on effect is hypoxia and all the damage that can cause. Now, that's just one reason why we can end up with pulmonary edema. And you'll recall from our previous tutorial, we thought about both anaphylaxis and sepsis having these inflammatory markers that act upon the walls of the capillaries and make them more porous, make them more permeable to water. And this was things like histamine and bradykinins and sort of inflammatory markers like this. And we said that although the hydrostatic pressure might not be greater, it's probably slightly less if anything, there's much bigger holes, if you like, for the fluid to leave the intravascular space, to leave the capillaries and enter the tissues. And then on top of that, we have this situation whereby the pores or the holes within the capillaries are so large that proteins and cells such as white blood cells can leak out of the intravascular space and into the interstitial space, and in themselves then be exerting oncotic pressure. So they're drawing fluid out of the intravascular space as well. So they have more fluid leaving because the holes are bigger in the vessels, and then you have the fluid staying in the tissues because you've also got a leakage or a movement of these proteins and white blood cells and all the other things that have left the intravascular space and entered the interstitium. And just as this can happen in the systemic circulation, it can also happen within the capillaries, within the circulation of the lungs as well. And so consequently, if you have a lot of inflammatory mediators around, histamine due to an anaphylactic reaction, or endotoxins or bradykinin or tissue necrosis factor, and all these other inflammatory mediators that are around when you have a sepsis or an inflammatory response going, then you have this increased capillary permeability within the capillaries of the lungs, so you've got more fluid leaving, and then you also have those proteins and cells also leaving the capillaries and sitting within the tissues of the lung and drawing fluid, or rather preventing fluid from being drained back into the intravascular space. And again, that is another reason why we may end up in pulmonary edema. And this is why we see pulmonary edema in sepsis and pancreatitis and possibly in anaphylaxis as well. So in summary, we've looked at how the imbalance between the Starling forces of hydrostatic pressure and oncotic pressure can manifest as edema, and specifically as pulmonary edema. And we've looked at the causes of that. So we've thought about sepsis or inflammation, and then also how a failing left ventricle, which in health takes the blood from the lungs and pumps it around the body, well, if it's unable to beat well, it doesn't take the blood from the lungs as well, and so it gets back up a pressure, and so consequently you can also get pulmonary edema because of a failing left ventricle. Thank you very, very much for listening.